Carolina, services to deaf and hard of hearing people. We have two people who are going to present. One is Tressa Bateson, and the other is Barry Critchfield. Welcome to both of you.
I'm the Director of Services to Deaf and Hard of Hearing People for the South Carolina Department of Mental Health. Let me first say that in the Innovations Program book, we're listed as a disability program, and while we do serve multiple people with multiple disabilities, we are in fact a mental health program. In 1992, South Carolina was spending more than $1 million annually to care for 20 deaf patients in our inpatient facilities. Community mental health centers were accessible only through interpreters, and there were no residential programs where deaf residents could talk with the staff. This unfortunate state of affairs is still the status quo in many other states. Now in South Carolina, there are mental health professionals who are fluent in American Sign Language, and they're available in every mental health center. We have a community residence program where everyone has communication access, and state-of-the-art technology is used to treat more than 400 consumers every year. All this is being done at a lower cost than what we were spending to serve some 20 people in the early 90s.
My name's Tressa Bateson. I'm the director of the McKinney House, which is a residential program for deaf adults with mental illness. To understand why we're successful, you need to understand first why the previous approach, which was providing traditional mental health services with an interpreter, did not work. You're hearing my words to an interpreter. There's automatically a distance between us, a different kind of relationship than when you were listening to all of the other presenters. Working with a clinician like myself, who can communicate directly, means our consumers are no longer forced to endure the intrusion of a third person into what ought to be a confidential relationship. This may be novel or disconcerting for you, but for a deaf person with a mental illness, it can be frightening and oppressive. It's that simple change, using culturally competent staff to work directly with deaf consumers, that's the basic innovation behind our program. Using this model, the disability of deafness fades into the background, allowing us to focus on treating the mental illness. This one change in perspective required major changes in the mental health delivery system. The low incidence of deafness, the scarcity of qualified personnel, required the provision of regional services, itinerant staff working within multiple mental health centers. The residential program was built and operated by the state because no private provider had the needed expertise. A central TTY hotline was developed because the local mental health centers did not have the equipment or the knowledge to handle incoming TTY calls. Telepsychiatry and video conferencing were piloted because of the difficulties inherent in having one psychiatrist or consulting clinician be available in each mental health center across the state. Prior to the establishment of the Deaf Services Program, lives were being lost. This may have been literally in the case of the suicide of the deaf patient who couldn't communicate with their therapist and could not call the local crisis line. It may be figuratively in the case of the deaf patient hospitalized for years because she could not explain to her treatment team what was going on inside her mind, and the treatment team lacked the knowledge to see beyond her deafness to treat her. This was the case of Susan, who was initially hospitalized as a teenager by her family, who thought all deaf people behaved the way she was acting. Her family, her doctor, the hospital staff had no way to understand what she was trying to express. When they did bring in sign language interpreters, her sign language was too confused, too psychotic to be understood. When she was placed in the new deaf inpatient unit and around sign language on a daily basis, her language started to improve. We established enough communication to explain her hallucinations and delusions, and now she lives in her own apartment, moved through our residential program, pays taxes, works in a local fast food restaurant, and daily tells us how much she enjoys being independent.
For many of the changes that we proposed, we were told that it would be ineffective, non-feasible, or it simply isn't done that way. A paradigm shift was clearly called for. Many programs in our department now that target small populations and special populations are emulating these programs that we piloted a number of years ago. Sadly, only a few states have taken the initiative to provide direct mental health services to the deaf community. This results in lives being lost unnecessarily to institutionalization, to suicide, to child and spousal abuse, all across this country. Yet we have seen that where states have adopted the South Carolina model, even in pilot projects, they've achieved similar benefits. It's our hope that through the efforts of programs like Innovations and the National Association of State Mental Health Program Directors, other states will start providing these services without needing the court's involvement, which often leads to solutions which are inefficient or unsatisfactory. South Carolina is a small, poor, rural state. And as we often say when describing our program, if we can do it in South Carolina, it can be done in any state.
Thank you, Luis.
What has been the main obstacle to providing services directly as you do?
Really, I think in answering that, finding qualified, culturally competent staff and keeping them within our state system. There aren't many people out there who have the focus and specialization, have the mental health training, have the sign language skills, and who are willing to move to South Carolina. If we've got the staff, other states get a little envious and are quite ready to steal them to set up their own programs. So that really has been our biggest impediment, keeping qualified staff.
Bill Klinger.
Yeah, I think you note somewhere in your application that there was some tension between the deaf services team and the mental health services team. That there was a sense of tension or competition, if you will. How serious was that? Do you feel you've overcome it? Is it still a problem?
It was only a tension in the sense that we were proposing to do things in a different way. To give you an example, mental health centers have a catchment area, a regional geographic region that they serve. Because of the low incidence of this population, we were proposing to have a counselor work in various catchment areas, the same individual, traveling from center to center and seeing deaf people close to their homes. That was a new idea. That was an idea that was foreign to the thinking at that time. But as I said, now other small population service areas are doing the same thing.
What percentage of the deaf people in South Carolina do you not reach? Or maybe what percentage do you reach? And do you have a much better position, much better percentage in South Carolina than states that do not have the program?
As I said, initially we were serving 20 people in the entire state of South Carolina. This past fiscal year we've served about 425. Those people, those additional 400 people didn't just materialize in South Carolina. They'd always been there. And they exist in every state in this country, but they're virtually unknown and invisible to the mental health agencies.
Are you reaching most deaf people in South Carolina today?
We hope we are, yes.
How do you measure success, quantifiable success?
I think when we're looking at measuring it, we look at the length of hospital stay. For example, 5 years ago, the average hospital stay was 9 months. Now it's about 15 days. We use a global assessment of functioning, the GAF score, that we have been able to show that clients, when we look at them during an assessment process, we can see a steady improvement over 6 months and over a year, an increase in their GAF scores. We also measure how long it takes a person to go through from the hospital, through the residential program, and out into the community, which is under 2 years. For the hearing programs, they're over 10 years on an average. We seem to make a lot more progression without a lot of pauses.
Can you explain how the difference between 9 months and 15 days, that's such an extraordinary change? Is that because people, when they first went in, had been so unattended and problems had become so entrenched that they needed longer hospitalization for mental purposes?
No, it's because there was no services available to them. They were placed in the hospital. We had a woman who was in the hospital for over 30 years because there was no services there. She was just placed and left. So, you know, really the number's a little bit deceiving, but it was just now that we have services available, they don't need to stay in the hospital. We have a community support system that's ongoing and out there.
These are mental health services.
That's correct. If I could add just a little bit to that, South Carolina is not unique. We have consulted in a number of states, and we find the same thing existing virtually across this country. The lack of trained professionals that are able to serve this population is a severe lack.
I wondered if you could describe a little bit your relationship with the other providers of variety of mental health services. I mean, you're sort of dependent upon them in some instances to not only work with you, but refer patients to you?
Indeed, we are. We have a very cordial working relationship with inpatient facilities, with outpatient private providers. We're seen as a resource to those folks that they didn't have previously. And in the age of managed care, where capitation and other factors go into place, we are a sole provider of service that's not available to many of these private individuals.
Ms. Bateson, we thank you in particular. You have a capacity to communicate in ways that actually are superior in terms of reaching us, and thank you for that.
Thank you. And when are you going to start learning sign